Hello, hello friends. Good afternoon to all of you. Myself, Dr. R.K. Bajpayee, President of FPI, welcomes you all in this Festival Academic Series, Part 3, arranged by Thane Unit of FPI. Today's speaker is Dr. Vaibhav Keskar. I welcome him. He will enlighten us and he will deliver his lecture on the burning issue of management of UTI. And second topic is approach to shoulder pain by Dr. Swapnil Jamre. Dr. Ramchandani will moderate the session and Dr. Ajay Singh will give vote of thanks. I welcome to all of you to Janak also, Janak, our enthusiastic secretary of FFPI. And next webinar will be on next Wednesday at the same time by Pune unit. Welcome to all of you. Over to Dr. Ramchandani. Dr. Ramchandani, please. Dr. Ramchandani, please unmute yourself and give the introduction of Dr. Vaibhav Keskar, most popular surgeon of Thane. Dr. Ramchandani, please unmute yourself and give introduction of Dr. Vaibhav.
Unmuted. Okay, sir.
Dr. Vaibhav?
Yeah, thank you, sir.
Ah.
For a kind introduction. Shall I take on?
Yes.
Where's the display for that? Dr. Keskar's display? Hello, good afternoon, everyone. Today's session will be, the first session will be the burning issues and management of UTI by Dr. Vaibhav Keskar, Director of Kimaya Kidney Care Center at Thane. Can I have the screen, Dr. Kimaya? Dr. Keskar. Deepak. Thank you, Dr. Keskar.
Good afternoon, everyone. Am I audible?
Yes, sir.
Okay. I'm sharing my screen. Is it visible?
Yes.
Yes. So, very good afternoon, good evening now. It's 4 o'clock. Thank you, FFPI, for inviting me for this talk. In next 20 minutes, I'll be talking about management of urinary tract infection. And focus of this talk will be choosing the right antibiotic. So we'll go by discussing a few cases. I'll start my talk with this case. This kind of scenario is very common in our clinical practice. So we see a 34-year-old female who presents with lower abdominal pain, dysuria, and increased urinary frequency for 3 days. There is no history of fever. We examine and we find that everything is normal on examination, including abdominal examination. So we come to a conclusion that because this young lady has dysuria and abdominal pain with urinary symptoms, this is urinary tract infection. So obviously, whenever we see such a case, the first question is whether this is urinary tract infection or not. So once we decide that this is UTI or not, we'll come to that. We have to answer a few questions before we go for investigations and management and treatment of this case. So I'll discuss one by one whether this is urinary tract infection or not. So urinary tract infection is by symptoms and lab tests. In lab tests, we go for urine culture, and where if there is significant bacteriuria, we label this as urinary tract infection. If there is fever or there is history of certain complications in past medical history, this is more likely to be kidney infection, which is called as acute pyelonephritis. We call this as upper urinary tract infection. versus lower urinary tract infection, which is usually the infection of bladder. We call this as cystitis. There, usually we do not have history of fever. There are just lower urinary tract symptoms. So it is very important to differentiate between upper and lower urinary tract symptoms. So we try to answer the second question. The third question is, based on the history and examination, we try and see if this is complicated UTI or non-complicated UTI. What do we mean by complicated UTI? I'll come to this question in next slide. And we try and answer the last question, severity, whether this is mild infection or severe infection. Severe infection in the sense there is a systemic inflammation and sepsis, low blood pressure, patient is vomiting, it's not taking anything orally, there is a rise in creatinine, which is called as acute kidney injury. So whether this is severe disease or non-severe disease. So whenever we see any patient in our clinic and who presents with the symptoms that this young lady had, we try to answer these questions. So the diagnosis of UTI is based on bacteriuria in presence of symptoms. Bacteriuria is generally more than 10 raised to 5 colony forming units per ml. People also have pyuria. Almost all the patients who have bacteria also have pyuria. Rarely someone may have only bacteriuria but no pyuria, and other way around is also seen, which is called as sterile pyuria. So not all the patients with pyuria will have urinary tract infection. In the interest of time, I will not discuss pyuria where there is no urinary tract infection, that is sterile pyuria. But I would like to direct our viewers to this very nice NEJM article on sterile pyuria. So whenever we analyze this data, we have to follow certain rules. So while managing urinary tract infection, we have certain rules. So first rule is always send urine culture. There's no exception. Exception is there in every case, but this is the first rule. And the second rule is don't mess with the first rule. So there are very few conditions where we can manage urinary tract infection without sending urine culture. For all practical purposes, sending urine culture before starting antibiotic is very important. And the method of sending urine culture is also very important. It has to be midstream urine. Genitals need to be cleaned before sending a sample. The sample needs to be processed as early as possible. So there are certain rules of sending urine culture also. So we should follow this rule and never mess with it. So why do we want to send the urine culture? So we know that commonest organism causing urinary tract infection are gram-negative organisms, and on that, in that list, E. coli is the most common organism. Others like Proteus, Klebsiella, and Pseudomonas are rare. Gram-positive organisms may account for almost 20% of the urinary tract infections. In hospitalized patients, this is a bit different story. E. coli are seen in fewer patients. Still, it is the commonest organism. So, if this is the case, why do we want to send the urine culture? So, the reason is the ground realities are changing. So this is the data. This is unpublished data from our microbiology department. I was in Bombay Hospital back then. So in 2017, we collected the data from almost 700 urinary tract infection cases. From all those cases, only 43% organisms were E. coli. So the atypical organisms are on the rise. Of course, this is a biased data. This is from a tertiary care center. This is not the community data. But the point here is the atypical organisms are becoming more and more common, more so in ICU. The samples received from ICU have predominant other bacteria other than E. coli. So it is very important to confirm whether there is urinary tract infection present or not by sending a urine culture. It will tell us about the kind of organism we have. So complicated versus uncomplicated. What is complicated urinary tract infection? So whenever there is a young lady coming in with just fever, urinary tract infections, because it is pyelonephritis is common in young ladies, it is called as uncomplicated urinary tract infection. In those ladies, we generally do not find any structural abnormality or immunosuppression or any other factor. Versus there is a group of patients where there is certain anomaly which makes the treatment difficult. For example, urinary tract obstruction, presence of a stone or enlarged prostate. There is some functional abnormality sometimes. For example, neurogenic bladder. Bladder is not emptying properly. There is presence of foreign bodies at times. For example, urinary catheters, DJ stents, or there is presence of other complicating risk factor, for example, renal transplantation, acute kidney injury, or immunosuppression. So all these factors make a urinary tract infection complicated, and this has bearing on deciding the management. So we should always answer this question. So next question you have to answer is severity, as we said. So once we send the urine culture and wait for the results, we have to start antibiotics. So how do we decide that? We decide that based on our own data. In our institute or our city or our region, whatever the prevalent organism is, our antibiotic should cover that. So previous cultures in this patient as well as in our practice do help us decide the appropriate antibiotics. So not all the antibiotics are appropriate in a given case, in an index case. Risk factor for antibiotic resistance are more than 60 years of age, prior UTIs, recent hospitalizations, complicated UTIs, presence of urinary catheters, or chronic medical conditions. So in this group of population, you will not select a baseline first line antibiotic. You have to consider that there is resistance and you have to start with appropriate antibiotic. So empiric therapy. So you have, in this lady, we have suspected urinary tract infection. We have sent off the culture and we are waiting for the results. And in the meantime, we want to start antibiotic because this lady does not have any severe symptoms or doesn't give any history suggestive of complicated UTI. We may start with a basic antibiotic, for example, nitrofurantoin, cotrimoxazole, or fluoroquinolones. In certain patients, we do have to use third generation cephalosporins or piptaz or carbapenem for that matter. And nowadays in ICUs, we may have to use higher antibiotics like colistin also. But for all practical purposes, even nitrofurantoin, cotrimoxazole are good choices for urinary tract infection. So let us come to the second case. Let us develop this flow of thoughts into by discussing this next case. This is elderly lady with diabetes, 58-year-old. She presents with fever, lower abdominal pain, and dysuria. So we assess this lady, we suspect urinary tract infection. We send off all the investigations. One of them is urine routine microscopy. It has 30 to 40 pus cells. So we send urine culture. So it comes back with a report of E. coli, which is pan sensitive to all the basic antibiotics. Before getting this fever, her baseline creatinine was 2. That labels her as chronic kidney disease stage 4, and she also had albuminuria. So given this background, our diagnosis becomes urinary tract infection. Here, because the lady has fever, we label this as upper urinary tract infection, which is pyelonephritis, acute pyelonephritis. And because she is stable, we label this as non-severe. And then we go for treatment with nitrofurantoin for 7 days. So my next question is, anything should have been done differently here? So it's difficult to interact here, but I'll just go ahead with the next slide. So answer to this question lies in the knowledge of pharmacology. So pharmacokinetic considerations are very important when we choose the antibiotic. So whenever we have oral antibiotic, stomach or intestine has to absorb it. Then it achieves certain blood level. And once the blood level is achieved, kidneys take up that antibiotic and excrete in the urine. So if I want to use one antibiotic which has to penetrate kidney parenchyma, I have to have a good blood level. And if I have to use one antibiotic for urinary tract infection, lower urinary tract infection, it has to have a good urinary concentration. So drug which does not attain urinary concentration cannot be used for cystitis. or for that matter, drug which does not penetrate renal parenchyma cannot be used for treatment of pyelonephritis. So when we choose the antibiotic, we should know which antibiotic penetrates kidney parenchyma and which antibiotic achieves urinary concentration. So in this case, we used nitrofurantoin. But nitrofurantoin has good urinary concentration. It is good for cystitis, but it has no renal parenchymal penetration. So it is not useful for pyelonephritis. So in this case, the choice of antibiotic was probably inappropriate. And also her creatinine was 2, GFR was low. So below GFR of 60, nitrofurantoin tends to accumulate and may cause neurotoxicity, neuropathy, peripheral neuropathy. So probably here nitrofurantoin was not a good choice, and we should have gone for either fluoroquinolone or third generation cephalosporin. So let us go ahead with another case to continue this flow of information. So this is again a lady with diabetes, has also hypertension and CKD, baseline creatinine is 2.3, has fever, vomiting, but is hemodynamically stable. Her blood pressure is fine. Her urine routine shows plenty of pus cells. You send off the culture and start empiric treatment with cefiporazone sulbactam, which is third generation cephalosporin. The culture comes back as E. coli, and it is significant bacteriuria, more than 10 to the power 5 colony forming units. But the report reads like this. This is not pan sensitive like in previous case. Uh, so the only antibiotics that would work are amikacin, aminoglycosides, meropenem, that is carbapenem, and higher antibiotics like colistin. Also in the list are fosfomycin, nitrofurantoin, and tigecycline. So in this case, this is called as multi-drug resistant organism. There are several causes of resistant E. coli. We all are familiar with beta-lactamase producing organisms, and this particular organism is called as AMP-C beta-lactamase producing E. coli. So in this case, the simple third generation cephalosporin will not work. In this case, we'll have to go for a different choice based on the culture sensitivity report. In this case, because this was pyelonephritis, ideal choice would have been carbapenem or cefepime. If this would have been just cystitis without fever, even nitrofurantoin or fosfomycin would have worked very well. So let us go to the other case. So we have seen a simple cystitis. We have seen a case of pyelonephritis with a good E. coli, good in the sense pan sensitive. We have seen a case with a difficult E. coli, which is drug resistant. So let us see this elderly gentleman. He is 79-year-old male, urinary presence with urinary frequency, dysuria, and fever. He was treated with nitrofurantoin for similar episodes 6 months back. He has normal renal function. His urine culture shows extended spectrum beta lactamase producing E. coli, ESBL, what we call this as ESBL. So here the antibiotic sensitivity report looks like this. We have a look at the report, and we appropriately start him on piperacillin tazobactam, and he completes the therapy, and outcome is good. So let us talk a bit about ESBL producing organisms. So almost 10 to 20% of E. coli and Klebsiella nowadays are ESBL. And what is ESBL? Is it produces an enzyme that will degrade the common antibiotics. So the risk factors are mostly hospital-acquired infections are ESBL, but nowadays things are changing. Even we are seeing community-acquired ESBL infections. So if someone is staying in the hospital for long, there is likely that ESBL organism is isolated in urine. People with diabetes, people with recurrent UTIs, people with recent antibiotic exposure tend to have ESBL E. coli. If there is only cystitis, we can use nitrofurantoin, which works well for E. coli. Also, we can use oral fosfomycin. If it is pyelonephritis and the organism is ESBL, we can use carbapenems, which are the preferred antibiotics. Carbapenems are meropenem, imipenem, ertapenem. We also can use cefepime and aminoglycosides. So let us come back to our own data. In the data I just showed, Of the 700 odd urine samples, we had almost 240 cases of E. coli growing in urine. And I would like to point out to the fact that if we would have used ceftriaxone or cefiperazone sulbactam as first line of drug, only we would be correct only in 30 to 50% cases. So this is the kind of antibiotic resistance we are seeing nowadays. So that's why in ICU or in a severe case, we may have to use higher antibiotics straight away. Same thing for Klebsiella and Pseudomonas. The commonly used antibiotics are losing their efficacy against these organisms. So why is this happening? Why are we seeing so many resistant cases? This is not good at all. We are running out of antibiotics. Why is this happening? This was a good paper in BMJ published in 2017. It shows that the exposure of antibiotics is increasing. So we always discuss about indiscriminate use of antibiotics. Antibiotics where they are not required, or inappropriate dose, inappropriate duration, that leads to resistance. But there are other sources becoming common also. We are having more and more antibiotics in our environment. Probably pharmaceutical factories are contaminating our water, and this has been proved at least one or two papers from Hyderabad, that the local water source was contaminated with the antibiotics. Of course, if we have drink this water day in and out, our intestinal flora will be exposed to this antibiotics, and our flora will already be resistant to these organisms, these antibiotics. Uh, Same thing is happening in poultry. If animals are given antibiotics, indirectly they may reach humans, and this is the probable. This is the multifactorial etiology of seeing more and more resistant cases in daily practice. So, what should we do? How should we go about? We have to think ahead. We have to see how we are going to practice 10 years down the line. So antimicrobial stewardship is essential. We have to use antimicrobials only when appropriate. And choosing a right drug is very important. Right dose is important, and right duration is important. And we have to de-escalate the antibiotic once we have culture sensitivity report. Even if we start, for example, third generation cephalosporin to start with, if the culture comes back and it is sensitive, we can de-escalate it. uh, so appropriate duration of any in UTI would be, if it is only uncomplicated cystitis, 3 to 5 days is enough. If there are comorbid conditions, we can extend it to 7 days. If there is acute pyelonephritis, in mild cases, 7 days treatment is enough. But in hospitalized sick patients, we have to give it for 14 days. Same thing is true for complicated UTI. If a pregnant lady is having urinary tract infection, cystitis is treated for 7 days, and pyelonephritis is treated for 14 days. So adequate duration is essential. So let me come to a next phenomenon that we see very commonly in our practice. This is called as asymptomatic bacteriuria. So typically the patient is asymptomatic. For some reason, we check the urine culture and it grows something. So here there is no sign or symptom of urinary tract infection, but still there is organism seen on the urine culture. So there is uh, uh, this condition should not require treatment except in two cases. One is pregnant ladies, where asymptomatic bacteriuria needs to be treated, and second, prior to traumatic genitourinary procedures, for example, stone removals, or if there is any trauma expected in that urologic procedure, we have to treat asymptomatic bacteriuria. Otherwise, it will lead to post-operative sepsis. So, apart from these two conditions, if patients are asymptomatic, we should not treat asymptomatic bacteriuria with antibiotics, especially given the current scenario of drug resistance. Even if we treat asymptomatic bacteria with higher antibiotics, it is likely that this organism comes back and even if it doesn't come back, it will not do any good to the patient. So we should refrain from treating asymptomatic bacteria. So the last leg of this talk, I would talk about the adequate dosing in presence of renal insufficiency. Nowadays, CKD is becoming very common because as a population, we are, growing older, we are getting more diabetes, we are becoming more obese. Obviously, incidence of CKD is also increasing. So many of us have low kidney function nowadays. How do we find? Historically, we have been using Cockcroft-Gault formula to calculate estimated creatinine clearance. And many of the texts, many of the papers use this creatinine clearance to tell us about the doses. So in a particular patient, we have to plug in those numbers: age, weight, and serum creatinine, and we have to calculate creatinine clearance. Based on creatinine clearance, we can see similar tables in several textbooks or Medscape. We just have to find out which category the patient is in. For example, if I have to give amoxicillin and patient's GFR is less than 10, so I will use the same dose in only once a day fashion, not twice a day. This is the example. So we should always check the creatinine clearance and then dose the antibiotic appropriately. So for certain medicines, we do not need dose modification. For example, ceftriaxone, cefiperazone, sulbactam. Dose modification may be required for some antibiotics. For example, Ceftriaxone requires it, or amoxicillin requires it. Some of the fluoroquinolones, for example, levofloxacin needs it, so on and so forth. Some of the antibiotics should be avoided altogether when there is renal insufficiency. For example, aminoglycosides, unless there is no other option. Nitrofurantoin, because we just saw why we shouldn't use it. So we should always inculcate habit to calculate creatinine clearance and see if we are giving the antibiotic in appropriate dose and frequency. So with these short cases, I come to the end of my talk. I would like to summarize my talk by saying that multi-drug resistance is growing even in community, not only in hospitals, but even in community. So patient may walk in with a report which has multi-drug resistant organism. So it is very important to send urine cultures before starting the treatment. And prevention of this resistance is important. So antibiotic stewardship is very important, and ascertaining renal function and modification of antibiotic doses is required as the prevalence of CKD is rising in our community. So with these short cases, I conclude my talk. Thank you for inviting me for this talk. I would just a different topic, but this year's 2021's World Kidney Day theme is living well with kidney disease. Uh, so I would like to enlighten all the attendees that we annually we celebrate the World Kidney Day, and this year we'll be pointing to the fact that people nowadays can live very well with kidney disease, and previously it was untreatable problem, but now it can very well be managed. Yes, thank you for having me here. uh, I'll hand over to Dr. Bajpai
Yes.
and Dr. Ramchandani.
Thank you. Thank you very much, sir. Very good, sir. But this you have given as a setup in a hospital, tertiary unit. But what about the GP? The patient comes, he shoots him an injection unknown, and then goes for an antibiotic on his choice without thinking. So that should be the criteria the day one when the patient drops in to my clinic
Right.
at the GP level. What should I give? Just
Yes.
give him a uroanalgesic? Can I give him a Citral or anything like that in that case? Immediate for relief. What would be your opinion?
Refer to my first case where there was a non-severe cystitis, and to my second case where there was non-severe acute pyelonephritis. So whenever a person walks in with features suggestive of urinary tract infection, I will first decide if this is UTI or not. How will I do that? By sending urine cultures immediately before even starting antibiotic, because even one dose of antibiotic may make the urine culture negative. So first thing, I'll decide whether this is urinary tract infection or not. second thing, I'll decide whether this is severe, requires hospitalization or not. If I come to a conclusion that this is UTI, doesn't need hospitalization, it is not severe, and it is uncomplicated. So my first choice as cystitis would be nitrofurantoin or Septran or fluoroquinolone, and in some cases amoxicillin. So I have these things to choose from. Of course, I will or change the treatment based on the urine culture report. If patient is having pyelonephritis, my options change. Now I will have to use either fluoroquinolone, for example, levofloxacin, or third generation cephalosporin or amoxiclav. If patient needs admission, cannot is vomiting, cannot keep the tablets in, I have to go for injectable third generation cephalosporin. So this is the algorithm for non-severe cases. The reason I was pointing out to the resistant cases is the prevalence is rising. More and more patients walk in, and we are just amazed that no, nothing works except for colistin. So we have to avoid these scenarios, and as a community, we can do that only by having antibiotic awareness. Antibiotic stewardship is very much required. Giving antibiotics only when required, giving antibiotics in the right dose and duration, and this is the thing we have to do in community, in our clinics, and that's how we will be able to avoid the insurgence of multi-drug resistant organisms.
Yeah, the second question is, women go to women gynecologists who start, say, nitrofurantoin or Septran, along with the flagella and all. Would the combination be appropriate in this case?
Yes. So yeah, this is syndromic approach. So urethritis also presents with similar symptoms. Burning micturition, increased frequency, whereas urethritis or vaginitis is appropriate. So we have to differentiate between urethritis versus cystitis, urinary tract infection. In urethritis, typically urine culture does not grow the usual organisms. So that's how I would differentiate between these two. But when they give a combination of nitrofurantoin and metronidazole or local clindamycin, I would say they are treating them syndromically for urethritis as well as cystitis. I would always send urine culture in that case too. Sir, you are on mute mode. You have to unmute. Yes.
Any other questions on the chat box? Let me see.
I should say one thing. Take home message of Dr. Vaibhav is that first go for urine culture, so that unnecessary antibiotics should not be given to the patient.
Yes.
Okay.
Yes, that is very important.
Yes.
Okay.
Thank you, sir.
Swapnil.
Thank you very much, sir.
Thank you.
We can go for the next lecture.
Yes. Ram.
Dr. Vajpayee, over to you, Karna.
Oh, yes. Dr. Ramchandani, please use the introduction of Dr. Damre.
Ram. No slide has been put up. Yeah. The next lecture, the next topic is approach to shoulder pain by Dr. Swapnil Damre, MS Orthopedic. Okay. Please, Dr. Damre, come on the screen. Please share it.
Can you see me?
Yeah, exactly. Go ahead.
Okay. Now, can you see the screen of my presentation as well?
Not yet.
Not yet. Okay. More. Invite chat, record, leave, and view. View my speakers. Screen. No, that doesn't work. Okay, so share screen. Yeah, share screen. Okay.
Yeah. Go to share.
Screen now. Right. Okay. Hopefully, I'll be able to get you to see it now. Hold on. Screen. Now, can you see the
Screen.
Screen now?
Share the screen.
You can
Share
see
your screen.
Please share करिए sir.
Hold on.
Deepak, do something. Deepak, what are you doing?
Right. Okay, so you can see me?
No.
You can't see me.
We can see you, but
We can see you.
You can't see the share screen. Okay, hold on. Share, press escape. Okay, here you go. Share. Okay, I need to click on share. I didn't do
Yes.
that.
Yes, yes, that's
Okay,
it.
now I think
That's
you
it.
guys can see me properly.
Yeah,
Okay.
please do, sir. Please continue the lecture.
Thank you. So, firstly, thank you so much to the Family Federation for inviting me. I'm going to give you a quick overview of how to, basically this is one of my talks about demystifying shoulders, where I give a talk basically about how you approach a person with a shoulder pain. Shoulders can be notoriously difficult to, work your way around. And vast majority of the time, what happens is physicians and family physicians will end up saying that it's a frozen shoulder when it isn't. So I'm going to try and give you a quick overview of what exactly it is. Starting off with, I'll just talk to you a little bit about anatomy, because without that, you won't be able to, sorry, my bad. There you go. The shoulder is a complex of three main joints. This is the glenohumeral joint. Then there is an acromioclavicular joint. And then there is a subacromial joint, the one below the acromion, which articulates with the humerus. The sternoclavicular joint is not considered a part of the joint. So these are the three main joints that form the shoulder joint as such. There is also the scapulothoracic joint, but again, that's slightly different. These are the three main things that are cause of source of pain, and the patient will come to you and say to you shoulder pain. And that's the main thing that you need to understand as to how you're going to approach shoulder pain. So looking at shoulder as such, if you look at the shoulder joint, it's a very shallow joint. The glenoid is a very shallow cup and the humerus is a full-on ball. So the reason why it stays centered on such a shallow ball is because it's surrounded by a whole group of muscles, the deltoid on top and the cuff muscles inside, which acts almost like what we would call gears. The deltoid gives the major power to the shoulder, whereas the rotator cuffs ensure efficiency of that power, so that, just in a way car does, if you have no gear, it will still work, but not as efficiently as if it was a geared car. And that's the main function of the cuff. So before we go any further into the shoulders, the one thing we need to understand is that you need to look at the neck. Okay? A lot of the times you will get a patient coming to you with shoulder pain and they will tell you that they have shoulder pain, the problem will be in the neck. So there are 4 pointers I would like to give out here, which will tell you that you need to look at the neck. Anyways, as an orthopedic surgeon, whenever I see patient with shoulder pain, I will always see the neck. But especially, in a busy practice, family physicians is really difficult. So main thing is, if the pain in the shoulder crosses your elbow and it goes down into your forearm, you need to look at the neck. If you get any pins and needles anywhere in the shoulder, anywhere else, you need to look at the neck. If you have a patient who has shoulder pain and also has vertigo once in a while, dizziness, you need to look at the neck. And also, if you cursorily ask if he has any pain or stiffness in the neck, if he says yes, he has pain and stiffness in the neck, then you need to look at the neck. So these are 4 main things you need to look at, because otherwise what will happen is majority of the times you will try to treat the shoulder. Treating the shoulder at a family physician level is not difficult. Simple algorithms you follow, and vast majority of them will be treatable by anti-inflammatories and physiotherapy. The remaining, the complex ones, obviously will need to be looked at by a specialist, but you will be able to get to know what exactly the problems are. So now there are, as a part of this lecture, to keep it short, I have only covered conditions which cause pain. So here are a list of conditions that you as a family physician is likely to see in your clinic. The top 2 conditions I would like to draw your attention to, mainly Parsonage-Turner syndrome and calcific tendinitis. A simple term for Parsonage-Turner syndrome is brachial neuritis and calcific tendinitis. These are 2 very painful conditions. I would say the 2 most painful conditions in the shoulder, where your patient is likely to come to your clinic and may even be in tears, has been unable to sleep for a day, 2 days, 3 days, and will be in tears. And the first thing you need to think of, Does the patient have, because any other condition, even relating to the neck or any other shoulder condition, is unlikely to cause the patient to be in tears or be a severe amount of pain. So these are the two main conditions that I'll quickly cover, because these are patients you'll come to your clinic and you'll be concerned as to what is exactly that is happening here and what we need to do to try and get the patient better. So looking at Parsonage-Turner syndrome or brachial neuritis is basically a viral infection that infects the brachial plexus. It's a neurological pain. So it's a very unrelenting, aching pain which is there all the time. And it can generally, not always, but be preceded by fever for over the last week or so. You can ask a history of whether they had any cough, cold, or fever in the last few days. Quite a few times actually you'll get that, but rarely you may not necessarily get it. And then the main sign of this pain, which is a brachial neuritis, is that the pain, even though it will be dull, unrelenting, and aching, any movement of the shoulder will not increase that pain. It will just stay static. Whether you move the shoulder, whether you don't move the shoulder, whether it's day, night, no activity, no motion will make it worse or better. It's just high level, steady, continuous pain. And that's something that should alert you to whether you're dealing with brachial neuritis. Combine that with fever. And not initially, if you see the patient within the first day or two, the pain will be so severe you won't be able to test it. But if the patient comes 7 to 10 days down the line and the pain has somewhat decreased, you will also find that the patient is starting to get weakness in his shoulder, because the brachial neuritis is causing the patient to have neurological injury, which can lead to some degree of wasting of the muscles and also weakness in the shoulder. So the patient won't be able to lift the shoulder. Now that needs to be differentiated from frozen shoulder, where even if you push the shoulder, it doesn't go up. Whereas with weakness, you push it, it goes fully up. That is the main difference here. But weakness is one symptom that you need to look at. So simple thing, patient is in pain so severe that patient's almost in tears. There are two things. One is brachial neuritis, another one is calcific tendinitis. With brachial neuritis, you look for fever, you look for motion, which is unrelenting and not related to movement, and weakness later on if necessary. And again, next one will be calcific tendinitis. Again, somewhat similar, still not as bad pain as brachial neuritis, but almost severe. Patients, these are the only two patients I've seen coming to clinic which will be in tears and literally crying out in pain. But the calcific tendinitis will be slightly different as compared to brachial neuritis. There won't be any prodrome of fever. Brachial neuritis can take place over 2 to 3 days, gradually increasing unrelenting pain. But calcific tendinitis, boom, it happens within 10 to 12 hours. You may get minimal trauma that they did some cleaning and that just literally triggered it, and now they're in tears for the last day or two. And the main thing you will see here is that it will be worsened by motion. So if the patient is in severe pain, sitting down, doing nothing, and you try to raise their arm, the pain gets much worse. And that should again alert you. Again, it's not brachial neuritis, but potentially calcific tendinitis. A simple X-ray at that point will show you a calcium deposition in the cuff muscles here, which I'm pointing to at this moment in time. But do remember that with calcific tendinitis, only up to about 70 to 80% of patients will show you calcium deposition at the initial stage. If you catch them really early, where they haven't had any problems beforehand, and they've just had it for the last day or two, you may get very, very fluffy, very diffuse deposits. And unless you have a really high quality digital X-ray, the likelihood is that you won't be able to pick up them. So, and they will obviously become more obvious later on. So sometimes if you have slight index of suspicion, you may need to repeat the X-ray at a later stage. Again, so the treatment for brachial neuritis is fairly simple. It's anti-inflammatory, is vitamin C is something that I tend to prefer as well. Steroids sometimes are necessary. Again, it's more specialized treatment, best of done by a specialist. And sometimes you may need to involve neurologist as well, especially if it spreads and it becomes more widespread and starts involving the forearm as well and can cause weakness in the forearm as well. Extremely rare, but not impossible. Calcific tendinitis is again a very treatable condition, easily treatable by local steroid injections into the shoulder joint. just above the cuff, or sometimes you may have to do an arthroscopic needling. You just put an arthroscope in the shoulder joint, you find where the calcium deposits are and you needle them and you decompress them. The calcium comes out, and I've literally seen patients where they've been in tears and you do an arthroscopy and later on in the evening they're smiling. And they're able to raise their hand up to 90, 80, 100 degrees and the pain is like dramatically gone. But again, index of suspicion is important. So these are two conditions, I would say, TRE patients. One worsens with pain, calcific tendinitis. One doesn't worsen with motion, that is brachial neuritis. Okay, these are two main conditions, severe pain. And then you start coming down to patients who have moderate to severe pain, which is not bad. Sometimes they can wait for weeks and months tolerating painkillers before they will present to you or even present to us. So the next commonest condition, again, this is so now I would say the top two conditions where the patients are in tears are fairly rare events, thankfully. You will see them very rarely, but impingement shoulder is the most common condition in the shoulder. The chances that if you have a patient comes to see you and has shoulder pain, and of course you ruled out the neck with all the 4 points that we talked of, and the patient has shoulder pain, the chances of the patient having an impingement is far more as compared to frozen shoulder. So impingement shoulder is much more likely to cause pain and is more common, especially nowadays where people, we have, become desk sitting cultures. We don't do much exercise. We're hunched over our laptops, and that gives rise to bad biomechanics in the shoulder and can cause impingement of the shoulder. What basically is impingement of shoulder is where you have what we know as a glenoid head and the acromion on top, and it can cause rubbing of the glenoid head against the acromion, and that can cause inflammation of the bursa just between the head and the acromion. These are the 2 bones there, and that inflammation of the bursa can cause severe pain. And some of the signs, as you can see on this X-ray, is spurring of the acromion. If you can see, there's a large spur that has come on both sides of the acromion, in the AP view as well as in the Y view. And as you see, when you raise your shoulder, that tends to rub against that lateral aspect of the acromion and can cause pain. Another sign of impingement shoulder is night pain. Pain during day won't be as bad. Typically, frozen shoulder pain, if you want to differentiate between the two, frozen shoulder pain will be fairly steady during the day, actually a little bit better during the night. Impingement shoulder will be steady during the day, a little bit worse during the night. It is very difficult for the person to lie on that shoulder because that acromion can dig into the shoulder and cause a lot of pain. And night pain is a good sign to pick up. Another thing that you will see in people with impingement shoulder is stiffness on internal rotation, where you have a patient who's unable to put his hand behind his back, and that causes pain. Okay, this is exactly opposite that of a patient with frozen shoulder, where I will show you that you need to do an external rotation where you turn your forearms outwards, and that causes them pain. And quite a lot of times I see natural history wise, I see patients who get an impingement of their shoulder, and then if that's left alone, gradually progress to a frozen shoulder. And then sometimes you have a combination. You have an impingement shoulder and as well as a frozen shoulder. And vast majority of the times, even when I'm treating these people, I will inject the impingement first, because majority of the pain is coming from the impingement, not from the frozen. The frozen shoulder tends to give rise to pain only when it's stretched out, and you go near a limit where it cannot be stretched out and you push hard, that's when it gets pain. At rest, frozen shoulder tends to cause very little amounts of pain, but impingement can cause quite a bit of pain even at rest. And during night, definitely more so as compared to a frozen shoulder. So if you have a combination, what I tend to do is I'll inject the impingement area with the bursa first. That gets rid of majority of the pain. And then the frozen shoulder, whether I inject or whether I send to physio, is up to how well the patient's pain has recovered. And if the patient's pain has recovered much better, then I send them straight to physio, because frozen shoulder can be dealt with physio as well. And if not necessarily, then I will inject the frozen shoulder through the glenohumeral joint as well. And that gets rid of a lot of the pain, and then you follow up that with physiotherapy. So if you compare impingement shoulder, the second most common condition in the shoulder is a frozen shoulder. Now, I've seen a lot of times that, patient comes to you with adhesive capsulitis, frozen shoulder, a scientific term for it, or periarthritis shoulder. These are all mean the same thing. But the key area is in a frozen shoulder, apart from stiffness, the first thing to go is external rotation of your shoulder. So if you have a patient who has a normal shoulder, you rotate the normal shoulder outwards, see how much external rotation the patient has. It can vary between 60 to 90 degrees. Normal shoulders tend to have 90-degree external rotation, but you always compare, because in some people, their shoulders tend to be stiffer. 60, 70 degrees may be their normal external rotation. And if you have an external rotation, you hold your arm to the side of your body like that, and you move it outwards and see how much natural external rotation they have. And then you compare that with the opposite side. Actually, that is a very sensitive sign of detecting a very early stage frozen shoulder. A frozen shoulder where the patient's arm going fully up. He doesn't have any problems with the arm going fully up. That part has not stiffened yet, but their rotation goes much, much earlier. Okay. So, for me as an orthopedic surgeon, when I see a patient coming in, sit him down, do external rotation of the normal side, do external rotation of the affected side. If there's a difference, I know there is a frozen component. It's very simple. So you do internal rotation, and if there is pain, that's impingement. You do external rotation and there's restriction and pain, that's frozen. And sometimes you have both. So stiffness in external rotation, slam dunk, even if they are going fully up, is frozen shoulder. Obviously, the range of motion decreasing in abduction and flexion is a part of the frozen shoulder component. And obviously, it's very easy for you as a clinician to know that you are seeing a patient with a stiff shoulder. The likelihood of frozen shoulder is very high. So the main thing I need to flag up is that frozen shoulder is a condition can initially be easily treated by a family physician, especially if you catch it early when there is external rotation restriction with not much abduction restriction. You can treat them with anti-inflammatories, you can treat them with ice, and you can treat them with physiotherapy. Generally, I would advise you to take an X-ray to make sure that you're not dealing with calcific tendinitis, an old one, because that can be quite resistant. But on the whole, frozen shoulders, non-complicated one, not post-traumatic one, but you had a fall and you get a frozen shoulder, that's not something you should ideally treat. But the commonest frozen shoulders are the ones which are naturally occurring. They just come with pain and stiffness. And as long as you ruled out an impingement shoulder, you're dealing with a pure frozen shoulder where external rotation is restricted, you can treat it. Two provisos here is try not to treat patients with frozen shoulder in diabetes and thyroid problems. They tend to be very resistant, and even in our hands, we find it very difficult for them to get a good, outcomes. You tend to treat them, they get better, they recur. So sometimes they even need arthroscopic surgical releases, and it is a difficult one. Now, but the one thing that we would love is if our physician friends can ensure that if you have a frozen shoulder, you're sending it to an orthopedic surgeon, that you control their diabetes and thyroid properly, because that is half the battle won. If you have a diabetes out of control, your thyroid out of control, the chances of us getting on top of that frozen shoulder is very difficult. There are other contributing factors. There are certain patients with cardiac problems that get frozen shoulder, certain cancers, but that's not really, these are not resistant ones. These are the two ones that are resistant, and these are the two ones that you can optimize the patient while you're sending him to us. That helps us deal with them faster and get them better faster. Remember, in uncomplicated shoulder, periarthritis or frozen shoulder, these are naturally recovering problems. You treat them early, anti-inflammatories, home exercises. If the patient is not willing to go to physio, even home exercise and anti-inflammatory and a basic X-ray to rule out any calcific tendinitis, and they tend to do very well. But complicated ones, you're best off treating the diabetes thyroid part and sending them onwards. So I would again reiterate, internal rotation, you have impingement, external rotation, stiffness, you have frozen shoulder. And if you start seeing patients like that, you will find that patients with shoulder pain are far more impingement, far less frozen shoulders. as a natural course of what I see in my patients. The other one is the third most common conditions. So the top two conditions that we talked are, remember, they are rare events. But the reason why I'm highlighted them, they are rare because we're talking about pain in the shoulder. So I started with the algorithm where I started with the most painful condition. But thankfully, the top two painful conditions are very rare. Commonest is impingement, then is frozen. And then third one is AC joint arthritis. There is this small joint at the top of your shoulder, which can become arthritic. And that can cause quite a bit of pain. This typically you will see in patients who are quite fit and active. And they're just complaining of that little bit of shoulder pain that is, always there, constant pricking, pinching, night pain is there. They're unable to lie on that shoulder. Classically, what they will tell you is that they can lie on that shoulder. But if they try to lie on this shoulder, they will get a huge amount of pain on this shoulder. So that is a classic thing that you will see with AC joint arthritis. It's the other way around with the impingement. Again, don't take this as a gold standard, but this is what I see in my patients. Impingement shoulders cannot lie on that shoulder. It causes them a lot of pain. They can lie on this shoulder. But AC joint, pure AC joint arthritis, there can be a mixed picture where you have a little bit of AC joint arthritis, some impingement, some frozen, so it can get very complicated. But pure AC joint arthritis, they will tell you that lying on this shoulder causes pain on this shoulder. So that is there. The main thing is focal pain. You ask them where the pain is. Most of the other conditions, they'll say whole shoulder hurts. AC joint, they'll say, sir, this point hurts. This point hurts like crazy. Everything else is fine. I can move my shoulder. Okay, everything is fine. But this hurts. There are certain activities I do. It hurts. If I'm sitting at rest doing nothing, I'm okay. Sometimes there can be some pain at rest, but it's very minimal. But it can be quite painful, especially at night. And the easiest test to do for a family physician is two things. First is you obviously press over that area where the AC joint is. The easiest way to do is follow your clavicle. And you follow your clavicle and you find where the area of the tenderness is. You press on it and it's painful. You're dealing with AC joint arthritis. And a confirmatory test would be to get the patient to cross his arm across his chest like that and give us a sharp, short jerk, just like that, and ask him where the pain is. Now, they should point to the top of the shoulder here. They shouldn't be pointing to the back of the shoulder, because if they're pointing to the back of the shoulder, it's again impingement. But if they point to the top of their shoulder, any kind of area at the top of the shoulder, that's AC joint arthritis. So direct tenderness, focal pain, night pain, and scarf test, you're looking at AC joint arthritis. Again, the way you need to think about it is what kind of patient will present this with. People who pure AC joint arthritis, nothing else wrong with the shoulder, will be seen in builders and laborers, people who are heavy manual workers. And that's where the problem is. A easily treatable condition, you can initially start off by treating with injections. Physiotherapy has absolutely no role to play here. And if the steroids fail, then arthroscopic excision of the joint completely relieves the pain forever. Biceps tendinitis, the fourth most common condition in shoulder joints that can cause pain. I also feel is a precursor to frozen shoulders overall as it comes later. The easiest way to find out is to press the front of your shoulder where the biceps tendon run and ask if the patient has any pain when you press on that area. And that's if the patient has pain on pressure in that area, that's where you have biceps tendinitis. Now, remember, most of these conditions, impingement shoulder, frozen shoulder, wherever you press on the shoulder, the patient will not complain of any tenderness, because there won't be any focal areas where the patient, you press and it hurts. There will be pain, but the pressure won't cause any tenderness. Tenderness and pain are different things. Pain is what patients tells you. Tenderness is what you elicit by pushing on an area. And impingement and frozen will not be tender, but biceps tendinitis and AC joint arthritis will be painful. There are certain special tests that you can do. Again, the treatment of choice is steroid injections and physiotherapy. And if it doesn't work with that, then the best thing to do is do an arthroscopic release of the biceps tendon or a teno-DCC. Cuff tears are, again, something that you need to be aware of, can cause a lot of disability if you missed early. The main difference between tears is whether they are traumatic or not, whether the patient got hurt and that's caused a tear, or which without hurt got tear. Sometimes you'll have patients who are older, 70, 80s, and they just try to try to get a thing across the table, and that can cause them initial pain. And that is the kind of thing that causes them the cuff tear. That's a different tear as compared to a traumatic tear where a patient has had a fall, jerked his shoulder badly, and that can cause problems. So traumatic tears generally happen in younger individuals, and vast majority of the times, the only treatment of choice is surgical, arthroscopic, or open. But when you have atraumatic or minimally traumatic tears in older individuals, 60-year-olds, 70-year-olds, I think a lot of these patients will do well with rehab and physiotherapy, and maybe sometimes top it off with some certain injections, and they tend to do well. For example, my dad has a cuff tear, is a supraspinatus tear, partial tear, full thickness partial tear, and I've conserved it, and I've done rehab on him. I had to inject it once, but he's absolutely fine since. So cuff tears in older individuals is certainly something that can be conserved, but not in everybody. Persistent pain, if the patient has done his rehab properly, you've done the injections, the pain is persisting beyond 3 to 4 months, you must ideally repair these cuff tears, because if you don't, then what you get is this cuff arthropathy, where the glenoid, which is sitting just below the acromion, escapes and starts migrating upwards. And once it starts migrating upwards, you can get a lot of pain and stiffness, disability, inability to do tasks of daily living, like pick up a cup or do your hair or do any at shoulder activity, forget over shoulder activity, even do at shoulder activity like fetching a jar. This is something that could happen in the elderly. You know, you have a 60-plus-year-old person who has had a cuff tear, and he has been initially conserved, but the conservative treatment has failed. And then the patient has either not bothered to treat it, or maybe the physician hasn't bothered to treat it, or maybe the orthopedic surgeon hasn't bothered to treat it, because it happens quite a lot. Not every orthopedic surgeon can deal with a cuff tear. So quite a lot of them sometimes will just conserve them, even when the conservative therapy isn't working. So they will conserve them. And this is what happens, where you have the glenoid which comes up, it is pushing against the acromion, causing a lot of pain. There is a severe arthritis in the glenohumeral joint, and all kinds of activities. There is night pain, there's day pain, there is rest pain, and you can't even do simple acts of daily living. And then the only choice, treatment of choice here is surgery, where you do a shoulder replacement. Okay, now shoulder replacements have come a long way. They used to be not that good, and since the last 10 odd years, we've got much better at doing shoulder replacements, and we are now having upwards of 90% survivorship in reverse shoulder replacements at around the 10-year mark. Still, 10 years is not a long time, I agree, but 10 years is better than nothing if for a patient who has been severely disabled by that pain. Long-term data is still being evaluated. It's not easy because these patients tend to be older. They have osteoporosis and maybe multiple medical issues. And it's very difficult for us to control for everything. But on the whole, treatable, and we can give them good function and good stability and good quality of life. And that's what matters in the end here about shoulders, because shoulders can affect not even knees can affect your quality of life as bad as shoulders can, because everything depends upon your upper limbs, and if any part of your upper limb is in a lot of pain, it's very difficult for a person, forget to even function, but to even sleep. It becomes really difficult for them. Now there are other conditions that about the shoulder that we can talk about, but these are extremely rare conditions and they are not as painful. Primary osteoarthritis of the shoulder, thankfully, is a very, very rare condition. I have seen only about 3 or 4 in India in the last 5 to 6 years, where they needed, they were so bad that they needed shoulder replacement. Again, these are fairly easy to treat, where you do a resurfacing rather than a replacement. The instabilities, again, I've included at the very end. Instability is a very common problem. Shoulder dislocation, recurrent shoulder dislocation is a problem. But again, it's not a very painful condition. Okay, the chances that a family physician will see instability are for pain will be difficult. He will present non-painful, where he's unsure of his shoulder and he's not sure whether the shoulder will pop in, pop out. It's not really painful. It's instability more like. And if it's an acute shoulder dislocation, again, the likelihood is he will go to hospital rather than come to you directly, because it needs a manipulation sometimes under anesthetic to get it done. SC joint problems, again, there's loads of those which I haven't included because that's not technically a part of the shoulder. Scapular dyskinesias, where there are a lot of problems that happen with the scapulae that can give rise to problem, where the patient complains not of really of shoulder pain, but the pain at the back of the scapula, especially on certain degree of motions, with clicking of the scapula also present. Again, extremely rare. The chances of the patient having a neck problem giving rise to scapular pain are like 90. 90 is also low. I would say around 99. And then 1 in 100 scapular pain might be actual scapular problems like scapular dyskinesia. There are many more, but this is a taster. Remember, the most painful conditions are brachial neuritis and calcific tendinitis. Easy to spot the severity of pain. Conclude, I would say, easy to spot severely painful conditions. One is unrelenting pain, not related to motion. Another is also unrelenting pain, but worsened by motion. So that's brachial neuritis and calcific tendinitis. Impingement shoulder, quickly, internal rotation pain, impingement shoulder, external rotation pain, frozen shoulder. And AC joint arthritis and all those others are fairly low on the list. Those top 4 will give you 90% of shoulder pain explanations. Then the rest 10%, everything else fights in the rest 10%. On the whole, if you have shoulder pain patients, I would say as a family physician, 30 to 40% of them will be neck problems. 70% will be actually shoulder problems. And of the 70% of the shoulder problems, 90% will be top 4, not even top 4. Impingement and frozen shoulder will be, about 60% of that. And the rest, 30-40% will be all the rest of the things that we've been discussing.
Nice.
The only thing that you guys can deal with, I would say these are fairly complex issues. Neck problems, easy to deal with. You can deal with those. Early stage frozen shoulders, you can easily deal with. But rest of them generally require specialist input, including physios. And that's it.
Thank you very much. Nice.
Thank you very much. It was pleasant and very, very, very cleanly explained by Mohammed. Thank you very much, sir.
Thank you so much.
Are there any questions, sir? Deepage?
Sir.
Any questions in the chat box?
Sir, Dr. Swapnil,
Yeah,
one question.
go for it.
You have explained very nicely pain, but there is no pain in the shoulder and mobility is restricted.
Frozen shoulder.
Frozen shoulder.
Frozen
In-
shoulder.
in this,
That is a stage 3 frozen shoulder where completely only the frozen component remains, and that causes stiffness. Okay. I will attach provisos.
just see my shoulder.
Yeah, I saw you do that, Dr. Bajpayee. All I'll ask you is that you do external rotation of your good shoulder and you do external rotation of your bad shoulder. You will invariably find that the external rotation of your good shoulder as compared to external rotation of your bad shoulder. That's frozen shoulder. Simple. Okay. Now there's always possibility that you could have cuff tear arthropathy, primary osteoarthritis of the shoulder, but that's very, very unlikely. Common things are common.
By giving steroid, mobility can come.
Yes, absolutely. Now, with frozen shoulders, I tend to inject. I inject almost all my shoulders. I'll inject. Okay, only the acute tears, the acute young people, I will not inject. Anybody 50 plus, I'm always doing conservative first. Inject, physio, rehab, and anti-inflammatory. With the frozen shoulder, I tend to have a slightly different technique where I don't just inject the glenohumeral joint with steroids, but of what we know as hydrotherapy, where joint. Okay, so I fill the joint up with around 30 ml of saline, stretching the capsule. Of course, also including steroid in that 30 ml. So the patient, the patient goes like, oh, and like, how much of and that's a well documented technique. described by a Japanese orthopedic surgeon. He does it in his clinic itself, where he uses up to 50 ml also, where he literally stretches, and gradually breaks the adhesion. I have not had so much, guts to do it in my OPD clinic yet, but I have gone from 10 ml to 20 ml to 30 ml. But again, I'll see my patient, the person who I think can tolerate that kind of pain, because it is transiently a little bit odd. It's not pain as in pain, but it's a very odd sensation to get that joint to distend so much.
Right.
And that works very well. If that doesn't work, then it's surgery. Surgery means not manipulation. Manipulation under anesthetics are slam dunk easy way. You don't get any cuts. You just do a manipulation under anesthetic. As long as you're not a diabetic thyroid person, it tends to solve your problem. And if you're a diabetic thyroid person, then what I tend to do is I will, after a manipulation, put a catheter into your subacromial space and give you analgesics every 12 hours to keep the pain down. And do physiotherapy for you in the hospital. We have got good anesthetists where sometimes we can put a catheter around your brachial plexus. Exactly, yeah. Not just a block. I mean, block for the manipulation, but then we have over the brachial plexus, where what we can do is top up local anesthesia to keep your shoulder numb for 5-6 days, where you're doing physio after manipulation. That is needed for people who are diabetics and thyroids, because we see that you do manipulation and they get full motion back, and 2 weeks later they'll come back and they're stiff again.
Yeah, there's a question here now.
Yeah.
1 second. What the post-operative stiffness of shoulder joint? What are the options?
Post-operative stiffness is, I'm assuming that in the common scenario here is you had a fracture of your shoulder, you had a plate put in and screws put in, and you have now got stiffness after that. That is the commonest post-operative stiffness scenario, right? So the thing to understand is there are multiple causes of what stiffness can be. Now, we will assume that the fracture has been fixed well. We will assume that the plates and screws have been put properly and they are not abutting against any of the bones, because you can, sometimes get that kind of problems. And then the only way solution is to take the metalwork out. But let's assume that there was a fracture. Let's assume it has been fixed well, and now the patient has stiffness. Easy, you treat it like a frozen shoulder, because that's exactly what it is. Post-traumatic is frozen shoulder, and the only problem with these things is until the fracture has healed, you cannot inject it. So it's a long-term solution where you do rehab. Up to 6 months you wait, and at the end of 6 months you evaluate. And if at the end of 6 months you feel that your rehab is not improving the range of motion, inject. And a majority of them will improve with the injection. There will be some resistant ones where, again, you're assuming fracture has healed and metal plate is beautifully sitting there. There's no other problem. And then you can, at 1 year, not before, you can at 1 year do a manipulation under anesthetic. Otherwise, your chances of refracturing the fracture are high. Another common problem with post-traumatic, assuming the fracture again is good and the metalwork is good, is post-operative stiffness is complex functional pain syndromes. Very underdiagnosed, and these can be very severely resistant to any form of routine treatment. Assessment is key, or having a high index of suspicion of whether the patient has CRPS is key, and then counseling the patient is key. Why? Because if the patient has CRPS, which is a cause of the post-operative stiffness, any procedure is likely to make the CRPS worse. So you shouldn't ideally be touching those shoulders. You're just doing rehab, counseling, telling them that this is CRPS, you will get better, don't worry. Because you operate on them, all hell will break loose.
Thank you. Do you use muscle relaxant along with analgesics, and which one? What do you prefer?
I generally tend to use physiotherapy as my best muscle relaxants. I generally tend to find that vast majority of the muscle relaxants are way overrated. The muscle relaxants I tend to use only for spinal problems, and that too sparingly. I haven't seen any need for muscle relaxants. When I use muscle relaxants only in the spine, only in mild problems. That's it. Those are the only indications for muscle relaxants for me. I don't use muscle relaxants anywhere else. I don't think they work.
Thank you. Any more questions, Dr. Bajpai?
Yes, no.
Thank you.
Very nicely explained, Dr. Swapnil
Thank you.
and Dr. Abhay. Both the speakers are nicely explained. Dr. Ajay Singh,
Yeah, Ajay Singh.
few vote of thanks.
Thank you, Dr. Vaibhav and Dr. Swapnil, for clearing the doubts of the general practitioners, family physicians, and very well explaining them very clearly and very well. You have explained everything. I also thank FFPI, Dr. R.K. Vajpayee and Dr. Janak Shah for such a nice and well presented webinar. And also thank Dr. Jagdish Ramchandani for conducting this webinar in such a fluid manner. Thank you, everybody. Thank you, lot. Thank you.
Thank you, Dr. Singh, Dr. Bajpayee, Dr. Ramchandani, and Dr. Shah for the invite.
Thank you, sir.
Thank you for the
Thank
Family
you.
Physicians Association for
Thank you.
this opportunity to present my case.
Okay, sir. Bye.
Thank you. Bye.
Bye.
Bye, sir. Bye, sir.
Deepak.
Deepak, I think.